All right. Thank you so much. As has been introduced, my name is Emmanuel Adewale, and I work with AP Public Health Initiatives. I'll be taking the session this evening. I want to appreciate the organizer for this opportunity. I also want to appreciate all those who have joined. I can see a very senior colleague I saw, Professor Kujobi. Shout out to you. Good evening, ma'am, and to every other person. I would like to continue. The title of today's webinar is Strategies for Quantitative and Qualitative Quality Control. And I'll be sharing that following this outline. So I'll give a bit of preamble or introduction to qualitative and quantitative quality control. We'll talk about basic quality control theories and practices, sharing experiences of what we have done on this particular field of quality management system. We'll talk a bit about how to monitor the data generated from running quality control. And then we'll look at that using WESGA rules and also the introduction of WESGA Sigma rules. We'll also touch base on external quality assessment, the proficiency testing. In all of this, we'll be looking at the relationship of each of these concepts with the ISO 15189-2022 standard. And then we'll touch briefly also on AI-driven QC and its use in quality control program and automation in modern laboratory. So before we continue, I've been told that we'll have a bit of a poll, and I have some poll question here. I'll be trusting the IT team to launch. Oh, thank you. So please, we want you to participate in these poll questions. It's about 3. The first one says, how does artificial intelligence, AI, contribute to QC in modern lab workflow? So please pick an option. And then the second one talks about the use of sigma metrics in laboratory quality control. So please, you try to see this as we go through the presentation. We believe we have answers to these questions, but it's important that we have your opinion on this even before we move on.
You may go ahead, please. Thank you very much.
All right.
You may continue.
Thank you so much. Okay, so these are the questions, and I believe we've been able to attend to that. So I'm going to the main presentation. I would like to start by asking, when we talk about quality, what exactly are we talking about? And we'll start that by knowing why it's important in the first place to even think about quality control, or to some of the managers or management representative, why do we need to invest in quality control or in quality management system? So we got this from a popular training slide on continuous quality improvements. And this particular one is from Greg Manning, an article on quality care in a nutshell. And the write-up says that the patient across the globe, regardless of where they are, whether in the country, outside the country, any part of the globe, defines quality in three ways and in a particular order as well. The first is do not harm me. The second is heal me. And the third is be nice to me. So healing is not the first part. When a patient gets to the hospital, the first thing they want is please do not harm me. Before they talk about, heal me or treat me and all of that. And lastly, please, as you carry out your duty, be nice to me in the process. Also, there's this statement about to healthcare providers, we are obligated to do no harm. And the first concept expressed to medical students is this Latin phrase, primum non nocere, which is first, do no harm. And in all that you do, that should actually ring a bell all the time. So this phrase, it's well known among healthcare workers, and it's been said to date back to the days of Hippocrates. And now the point is whether we are actually following this concept again. As we see, according to a study in year 2000, in a report by IOM, that about 98,000 people die from medical errors. And we are going to see what constitutes or what normally leads to medical error in a hospital setting. And also the same reports say that more people have died each year during mid-1990s from medical errors than from the all-known HIV/AIDS or breast cancer. So this is telling how significant the contribution of medical error to death can really be. I also took this from what the Medical Lab Science Council of Nigeria states to the inductees every year, or at the point of induction, that you put the interest and well-being of the patient above your personal interest and convenience. So, and I'm sure in other professionals in the health sector, we have one or two things that talks about obligation to do no harm. So what do we consider to be harm or benefit to patients? And the way I put it here is that any laboratory tests that is conducted without a valid quality control program is considered a harm to the patient. So if you had opportunity to go through ISO 15189-2022 standard, everything it's about the patients. The aspect of risk management, it's fully explained, and the expectation on the part of the lab in handling patient sample to ensure that the harm to the patient is reduced is actually stated almost every part of the clauses of ISO 15189. So we should start seeing in our laboratory operation, do we have laboratory tests that are conducted without a valid QC program? What are the alternatives? The standard was also clear where IQC programs or IQC materials are not available for a particular test. What are the acceptable alternatives? But in all of this, what is important is that there must be a quality control program for any of the laboratory tests that we are conducting in the lab. We're still looking at why quality is important. And consider this real life story. I mean, based on the publication that I came across. So a couple that had been married for 50 years were quite healthy, except that the man required blood thinner medication for a treatable heart condition. However, incorrect PT prothrombin test results led to several increases in his medication. The tragic part is that he died shortly after of a brain hemorrhage from over-medication. This is an example of laboratory error. The man was perfectly well, and he would have lived longer without even doing anything about the heart condition. But the lab in this case misled the clinician, and then it led to what we can call untimely death of that client. This is an example of consequences of laboratory errors and emphasizing the need to have a valid quality control program in our system. So wrong patient results can endanger patient lives, prolong suffering, add significant costs to patients' treatment in terms of money and time. And without even being able to address the issue, we had cases where the patients will pass on. So the right quality control approach will detect and prevent errors from happening. The goal of quality control is to detect errors and correct them before patient results are reported. And if I have to paraphrase this is actually from a standard QC QMS training curriculum. So I want to rephrase this, I'll say, the goal will be to detect errors and correct them so that patient results are reported accurately. So let's go to the theories and practices of quality control. Don't forget, we're looking at strategies, for quality control, the quantitative and the qualitative part. So I'll be talking about the qualitative and the semi-quantitative part before we move on to the quantitative part, which will take us to how to monitor data. Let's not forget that when we talk about quantitative data, we can only get this from quantitative assays. So talking about control, it's a material that contains the substance being analyzed, always included with patient samples when performing a test. In some instances, it is done as part of starting the day. So in some cases, you are not allowed to test, you are not allowed to run patient sample until your QC has passed for the day. And the way my manager those days used to put it is, what we want to be sure before we start introducing patient samples into the analytical system will be that my equipment is fine, ready to deliver, the operator is fine, the environment is fine. And when my QC produces an accurate result based on predetermined results, then I can say if I put my patient sample in the same analytical system, I will get a reliable result. So QC is used to validate reliability of the test system. That's what I just explained. And it's also run after calibrating the instruments to be sure that the calibration is fine, that the calibration has passed. And then, of course, it's run periodically during testing. So you are running like 24 hours, depending on the policy for the lab or what you have in your procedure. You may be looking at running QC at the end of every shift. So QC is a substance that is similar to patient sample. We are going to see under characteristic of quality control materials that it should be that type of materials that mimic the patient sample. They are used to ensure that the procedure is working properly. So when we talk about quality control should not be viewed as something that is an orphan, but it exists as a part of a system. There are more to this, but for the purpose of this presentation, I've looked at quality control as an integral part of quality assurance cycle, and both of them as part of a big quality management system. So when we talk about quality control being part of quality assurance, we say quality control look at the examination phase of the laboratory system. For laboratorians, we know we have the pre-examination, the examination, and post-examination phases of the laboratory system. So quality control focus on that examination phase. So we call it the inspection part of the system, where the product or service is assessed to pick up any defects or quality issue. This is a general definition of quality control. And I took this from the internet, I think from ISO Tracker website. So the quality assurance is the proactive part of the system, while the quality management system is that overall system that oversees and ensures the quality of the end product. And of course, these has other phases in that. So, and this slide explains the QA cycle, looking at the pre-examination, the examination, and the post-examination, looking at how, and there have been reports also that the laboratory errors actually are more at the pre-examination phase, more than even the examination phase. So when we're looking at the quality of the system, is not focused on just the testing part, but rather we look at where the source of the sample, and what are the activities that happen, before the sample gets to the testing bench. So QC is part of quality assurance system. And looking at some ISO definition of quality control, according to ISO 9000, the 2015 ISO 9000, for sake of emphasis, is actually the model of all the QMS ISO standards, and is the one that actually gives definition of most of the terminologies that is used, even in ISO 15189, ISO 15190, 17025, and every other ISO standard that is related to a laboratory system. So we get most of the definition, and then when we get to some of these other ISO standards, references are made to ISO 9000. So QC is examining control materials of known substances, like I said, either before, along with patient samples, to monitor the accuracy and precision of the complete process. So I've said this before, that QC is done to ascertain that the system is actually ready to take on the patient sample. So looking at where quality control was mentioned in ISO 15189 in 2022, if you look at clause 7, I think the first series of this webinar, when I checked, has talked about, or rather has introduced ISO 15189 in 2022 to the class. And then I'm sure then we thought we have 3 non-auditable clauses and 5 auditable clauses. So out of the auditable clauses, we have clause 7. And under the clause 7, 7.3.7 talks about ensuring the validity of examination results. In the 2012 version of the ISO standard, here the word validity was actually, the term that was used then was ensuring the quality of examination results. So for this particular one, that's the 2022 version, 7.3.7.2 talks about internal quality control, while 7.3.7.3 talks about EQA. So I took a part of the requirements just to illustrate what we'll be talking about on IQC. And this part talks about that the lab shall select IQC material that is fit, meaning that is suitable, for the intended purpose. What is the goal of QC? What do we want to achieve? And when you are selecting IQC material, these are the factors that you need to consider. So, talks about the stability. The matrix should be as close as possible to that of patient samples. This is where we talk about it, that the sample of QC material should mimic the patient sample. So talking about characteristics, which is similar to what we've seen in the requirement of ISO standard, it should be appropriate for the diagnostic sample. The value should cover medical decision points. Should have similar or same matrix with the patient sample, and it should be available in large quantity. So types of control materials, it could be DTS, it could be lyophilized, and if it's lyophilized, it requires very accurate reconstitution. What we'll be considering here will be whether the ancillary equipment, the automatic pipette, is calibrated to dispense accurate volume or not. So these are things that we look at when we're handling quality control material. And other forms of QC will be built-in controls. We are going to see example, especially for rapid diagnostic testing, and then the use of reference organisms, especially in microbiology. So the sources of control material could be those that are commercially prepared. There are a lot of commercially available quality control materials in the markets, in country. Could be controls that are made in-house, dry tube specimen. The example I have here, if you see the picture on the right, is actually a picture of when we're preparing dry tube specimen for HIV serology testing. So source of QC material could be DTS, will also be a control material obtained from another laboratory. In most cases, this is from a central or reference laboratory. And talking about the built-in control material, I explained this earlier on. Example is maybe the HIV testing kit. Talk about Determine, Unigold, or Start Pack, or all the other rapid diagnostic testing, including malaria. So it's automatically run with each test that is performed. And then, of course, it may not assess entire testing process, because this will not assess the other pre-examination issues that may affect the reliability of the result. And that is why we say that the quality assurance is actually broader than quality control. So still talking about the different forms of examination, like I said, we'll look at quantitative, we'll look at semi-quantitative, and we'll look at the qualitative part. So the quantitative measures the quantity of a particular substance in a sample, the quantity of the analyte in the sample, and the measurements should be both accurate and precise. We are going to see a definition or interpretation of accuracy and precision in some other slides. So quantitative measure the quantity of a particular substance in a sample, and the QC for quantitative test is designed to make sure that the patient results are both accurate and reliable. So looking at qualitative examination methods, they do not have numerical results. It's not a game of number. So for this, it's either there's growth or there's no growth. The result is positive or negative, is reactive or non-reactive, like the case of this example I'm showing here of Determine or any other rapid testing method. where the outcome of the test will be whether it is reactive or non-reactive. So also, when we do for the others, we look at whether there is growth or whether there is no growth. For semi-quantitative, this is a typo, it's supposed to be semi-quantitative examination method. So the results are expressed as an estimate of the measured substance. So here we look at, there's trace amounts, moderate amounts, talk about 1 plus, 2 plus. You look at the example of urinalysis. When you say, oh, the bilirubin is this, the glucose is this, and all other parameters, in the urinalysis test. It also look at number of cells per microscopic field, titers and dilutions in serologic tests in the case of advanced or wider tests and other methods. Okay, so let's talk briefly about stock cultures for quality control. We look at the use of reference strains. There could be in-house repository of developed strains. And then in all of these QC for stock cultures, you need to ensure that the media, the reagents and supplies work as intended. And one of the fantastic aspects of QC in this area will be when we talk about sterility testing and viability checks. So sterility will be that the prepared media is not contaminated, and you incubate, to check whether there will be unintended growth in the plate that is prepared. And the other part that talks about the viability check, we'll be talking about the use of reference strain to check the capability of the prepared media to support the growth of intended organism. So in the case of a popular example would be when you want to have a urethral swab culture and the organism of interest is an Neisseria gonorrhoeae, you want to be sure that, you have either previous strains of Neisseria that you can do as culture on the same prepared media. And if you can successfully grow your own strain, then it equally means that if that organism is in the swab that's collected, it should also grow that same organism. These are some common sources for obtaining reference strains. We have American type culture collection, the NCCC, the CIP, and kudos to my colleague. We have this also, the TB SRL in Italy. So these are some common sources for obtaining reference strain. And I was actually discussing this, that as a country, we should also have a repository of some of these collections. So maybe in the chat box, if I have colleagues that know where some of these domicile and reference strains can be obtained, I will appreciate if you can put in the chat box so we can all learn from.
If every lab follows these 12 quality essentials, then they will be at the same par. But it's not possible to follow all this.
So you are coming to Yellow.
All right.
Please. So we are trying to say improvement is not part of.
Can you please check your mic, Angela?
You understand?
Please mute yourself.
Hello. Angela, Ubu, can you please turn off your mic?
That the quality.
Right, thank you. So the other part we want to talk about, still in microbiology, will be stain management. It's important that we use a established standard operating procedure for preparation and reconstitution. Labeling is important. And as we know that with continuous use, the label gets to wear off. So it's important that the containers are well taken care of. If there is need to replace the label, then it should be. And then storage is, of course, very important. And the content of the label should include the contents, of course, the date of preparation, and expiration date. So QC for stains, as appropriate for particular stain, we can see example of the red cell morphology and white cell morphology. So also we can see the gram stain. I think on this part, we are seeing a kind of the precocci. So the essence of the QC will be at the point of preparation. So you want to see that when the stains are being used, it will give you, the desired outcome. So when you do this for a freshly prepared stain, it should be able to tell us whether we are going to be having a clear picture of what is expected or not. And also when we are suspecting, that maybe due to poor storage, the stain is no longer performing as expected, you do QC again and be sure that you are still getting what you're supposed to get. So this is a clear example of good quality of stain and poor quality of stain. Still talking about QC of growth media, it's important that we keep records for media that is prepared in-house. So we should be able to have documentation of when QC was prepared, the results of the sterility testing. I talked about sterility check earlier on as part of QC for media preparation. The date it was produced, the dates of expiration, we are not supposed to keep, and the storage, temperature. So all of these should be parts of each batch of media that is prepared in the lab. And all of these are recorded, in a dedicated media logbook. So also the pH, the sterility, the ability to support growth using stock cultures. I explained this earlier on. The frequency will also needed to be documented. So what I've talked about briefly is the part of semi-quantitative quality control, qualitative quality control. So we're going to that aspect of quantitative quality control where we talk about data, quality control data. So I've talked about these slides before, that when we talk about quantitative, we're talking about enumeration, we're talking about measurement, and that there is need for both accuracy and precision. So when we talk about quantitative control materials, the type that is available will either be the one that is acid, and this is what we have in most of the commercially prepared or commercially available quality control. So for acid, it means that the target values, we are going to see the statistics in the other slides that will show the important statistics, which is the mean and the standard deviation. The mean being the target value, it's predetermined by the manufacturer and is provided in the package insert of that quality control. There could also be some cheaper form, which is on acid. On acid, we mean we've just been able to prepare a quality control material that has been stabilized, and then you can have it available. But the lab will need to do a full assay, trying to run everything to determine those target value yourself. And then we'll talk about the example of in-house. post-sera that require full assay and validation. Here, if it is in-house, we'll also be talking about for how long you can store the sample without deterioration and at what temperature, what will be what you want to use to stabilize the QC. And these are examples of the quality control materials. I talk about material that to provide values covering medical decision points. So here we will look at controls that are critical high. So if you look at potassium, for example, you want to say, oh, if you take a reference range to be, let's say, 3.5 to 5.5 millimole per liter, you want to see that you have abnormal high and abnormal low control as well, so that if there is occasional cases of hypokalemia or hyperkalemia, you can actually look at control that will serve that particular decision point. So we look at all of this when we are choosing the quality control materials, to be procured. So we talk about the fact that the QC materials have to be similar to the test sample. It has to be mimic that sample. And this simply means if you have whole blood, if you're looking at hematology, maybe a full blood count control, you don't want to use like a plasma or serum-based control for hematology. And also, the control must pass through the same process that the patient sample will pass through. So in preparing and storing control materials, you need to adhere to manufacturer's instructions. You need to keep adequate amounts of same lot number, and you have to store at correct temperature. So if I pause a bit and explain why this is important at this point, some years back, when I was still fresh on the bench, we have in our system then, you need to make sure that your system is ready, for tests that particular day. And our lab, through the laboratory information management system, is linked to the head office, where every of your activity is remotely monitored. Meaning they want to know when your equipment maintenance was done, when your quality control was assayed, what results do you have. So it's a real-time tracking. And the expectation really then was you bring out your quality control sample from the fridge and you allow it to attain room temperature to stabilize by itself. So the efforts to try to bring the quality control material, to room temperature, bypassing the normal procedure of putting it on the bench to stabilize by itself, was the type that, the control vials, I think I remember correctly, there are control vials like this. And then what we tried to do was to bring it and was vigorously rubbing between the palms just to make it warm, trying to crush the temperature and make it ready. And I remember finishing a whole vial of hematology control because everything keep going, outside the acceptable range. So this particular scenario is to further emphasize the need to adhere strictly to manufacturer instruction, especially when we say, bring this out, keep on the bench, let it attain room temperature on its own. And what we do, again, will be that in my standard operating procedure, there will be the need for me to say, to avoid a case of ambiguity, I want to say, if you bring it out from the fridge, it should attain room temperature after placing this for, let's say, about 15 minutes or thereabout. Of course, this is subject to what has been practiced and demonstrated, and this cannot be documented to guide, scientists on the bench to say this is for how long you keep this before you can run the QC on your analyzer. The second point that talks about keeping adequate amount of same lot number will be that for each batch or for each lot of QC that you get from the manufacturer, you need to run it. We are going to see the process and get the laboratory running mean, the laboratory running standard deviation, the laboratory coefficient of variation, to be sure that you are getting the manufacturer's claim. This is part of verification process of new control material. And if you say we have to run this concurrently, with what you are doing, this, of course, will lead to consumption of reagents. So, but if you have the same lot number in adequate amount, in adequate sufficient quantity, this process will not be repeated more often. And then, of course, there is a cost reduction. So that is why it is encouraged, that you have adequate amount, especially for QC materials that can be obtained for that long. For things like full blockants that they don't really, last for maybe maximum of 2 months. You may not really be able to store them, in large quantity. But for some other things like immunoassay, for chemistry, that's, you can have it like in lyophilized or, in a frozen type, you can decide to do that. So the number of controls that we need, to run in the laboratory, it is good. If you have one level, at least you'll be able to say that, oh, my control is either in or out of the acceptable range. So here you'll be looking at, oh, my control is within plus or minus 2SD. Typically is the acceptable limit, but you won't be able to, of course, do other things. But it's better if you have more than one level, 2 levels of control. We have talked about the need to have the one that is covering normal range, and then at other high or low part of that assay, all of this covering critical medical decision points. So also for a one level of control, you cannot apply Westgard multi-row system, which will help you to monitor the performance of your quality control data. And of course, we'll be talking about Westgard rules. Okay. So another important thing I want to share with you is that the goal of quality control is to differentiate between variability that is due to chance from variability that is due to error. So we introduce quality control in the system so that we are not confused when there is variation in our test results. Normally, when you run a sample, whether it's quality control or patient sample, repeatedly, there is a variation that occur normally. Meaning, let's say, hematology, hemoglobin, for example, and you're getting, if you plug the vial the first time, let's say you have 12.5 milligram per DL. When you plug it in again, you are likely going to have maybe like 12.1 or 12.4 or 12.5. So there are things that affect the variation, that makes variation to occur when a test is repeated in the laboratory. And these are the factors that affect that makes variation to happen. And like I said, there is the normal variability that is expected. You are not expected to get the same thing every time. So it could be the operator's technique. Even if you are the same person, maybe this way you dispense the sample the first time from the pipettes might not be the way you do it the second time. It could also be inter-operators technique. These are the variation that happens. And remember, the lab is not manned by just one person. In most cases, you have people running shifts. So you can see somebody running in the morning, another person taking over in the afternoon. So the variation can be due to operators' technique. It could be environmental condition. Some of the, or no, not some, most of the equipment respond to temperature. So you see some equipment that perform better, they give you more reliable results when the environment is more conducive. And we know with things that happen, let's even look at the case in Nigeria, where you say, oh, if you are not on the power from the national grid, and we have to rely on, let's say, generator. So in most hospital settings, you say, oh, we can only put on one gen at a time. And I remember one of the facilities we support those days, the electrician will be going around the lab and will say, please, out of your 3 air conditioning units, you have to switch 2 off. You can only allow 1. It's bad in some instances where they've even disconnect the AC completely from gen. So when they are using gen, the AC will not be on. So it, of course, affects the environmental condition. And then, of course, the performance of the equipment will also be affected when this happens. And the one that is most intrinsic to the analyte itself is the performance characteristic of the measurement itself. Here, we'll be talking about the sensitivity of the assay, the specificity, the linearity. So we'll be looking at the performance character. All of these are things that contribute to variation when you repeat testing. But most importantly, QC will help us to differentiate between variability that is due to chance, which is what we have explained, and variability that is due to error. So if QC fails, then we know that variability is actually not due to operator's technique, environmental condition, or the performance characteristic of the measurement. But we'll be able to ascertain that, oh, there's an error somewhere. Somebody is not doing the work correctly. These are definitions of some of the terms that have been used. Precision, we talk about reproducibility. Each time you run this, you want to see how precise. We say that, oh, you should not get something, the same result repeatedly, but we're not talking about you run, let me use the same hemoglobin example I shared before, that you run the first one 12.3, and then you run maybe the next one, you're getting like 10.3. For a sensitive parameter like hemoglobin, that is way too different. So precision is expected for you to say that a test result is reliable. And then accuracy will be the closeness or the nearness of your measurand to the true value. In most cases, I tell people that for QC material, we know the target value because it was prepared and the value has been predetermined. So we can actually know that this is actually the target value. We can say this is the expected value of this particular parameter from the quality control. But for patient sample, and I say this often, that the target value or the true, not the target value, the true value is known by God. And in this case, only God will say, oh, at this particular time, this particular day, if you draw the blood sample out of patient A, the potassium results will be 4.3 millimole per liter, for example. So what we try to do in most cases as laboratorian will be to see, how do I get so close, to that true value? And this is one of the goals of quality control in a lab. Your result has to be accurate. Then your ability to maintain both precision and accuracy is reliability. What are the things that can cause inaccuracy or imprecision in the lab? We've talked about temperature earlier on, erratic of punctuation, plugged pipette tips. For most of the analyzer, we have what is called the pipetting system. For the robotic parts, you see there are some of the pipettes that aspirate sample. So you want to see that they are not plugged. And then if I also have to talk about the issue with automatic pipette that is manually operated, you see a case of if the pipette is not calibrated. So it could also either over dispense or under dispense. And we've seen cases that QC failure has been traced to a lack of calibration of pipettes. And what it means is, especially when you are trying to, maybe for all these lyophilized quality control material, when you are meant to pick a particular volume of diluent, it's either the pipette, if it's not calibrated, will over dilute or under dilute the control material in the lyophilized form. And then, of course, you can't get the acceptable range. So also, it means that if you are to use that same pipette to prepare a patient sample, you are not picking the accurate volume. And what that means also is that if you test it, of course, we know it's about garbage in, garbage out. So you will not be able to get the accurate result for that patient as at that particular time. So there could be issue with dirty cuvettes for things like all these manual spectrophotometers, poor mixing. If you don't mix the sample well, either before picking the sample or maybe in the process of testing. There are some procedure that says gently invert. There are some that say mix. There are some that are expected, to use some other equipment to even ensure adequate mixing. So if there is poor storage of control, it could also lead to evaporation of control, especially when you do storage. And also we have to talk about at this point, when you have aliquoted your sample into smaller quantities, it is important that you store at the right temperature. So if you are going to freeze them for a long time, it's advisable that you keep them in small aliquots such that once you bring it out, you are not taking it back. You are not doing what we call a freeze thawing, because it affects, the performance of the quality control. So we're on quantitative quality control. Though these implementation steps apply to all, whether it is qualitative or semi-quantitative, but here the main emphasis will be the implementation steps. What are the steps you have to follow when a lab is trying to implement a quality control program? The first thing will be that the policies and procedures has to be established. And the other things will be, apart from the policies and SOPs for the quality control, you also need to develop forms. There may be need to have charts where the QC data will actually be recorded. So everything that has to do with documents will be thing that you need to look at the initial stage of QC implementation. Then, of course, you need to assign responsibility. You need to train staff. One thing is that at times you assume that people should know how to carry out a particular responsibility. But it has been proven, of course, that you don't assume that people are knowledgeable about a particular procedure until you have trained them and you have records of training, you have records of competency assessment that this person is competent to carry out this particular duty. Of course, we talk about selection of quality control materials, looking at the one that will serve you and the one that is suitable for the intended purpose of that assay. Then, of course, we establish control ranges. We are going to see an example of how to go about that, especially when it is a new lot. And I said that as one of the reasons why you should not be changing lots every now and then, because the process of establishing the control ranges is both time consuming, and then it's something that we can avoid and ensure cost reduction if it is something that you do not too often. When the control ranges have been established, when we talk about control ranges, we'll be talking about, first of all, if the mean is supplied, the standard deviation is supplied, and then you've been able to run like 20 to 30 samples over a period of like 3 to 4 weeks, you're able to establish your new mean and your new standard deviation. And I'm going to explain why you need to do that, why you're not just using the manufacturer's mean and standard deviation. The next thing will be that using the ranges that you've established, what will be the value at plus 1 SD, minus 1 SD, plus 2 SD, minus 1 SD, minus 2 SD. You now need to develop graphs, which is LJ charts. So you develop this graph and you put the numbers, the data that will be at the mean, at the plus and minus 1 SD, plus or minus 2 SD, and then plus or minus 3 SD. So you can now, once the graph has been developed, then each day you're generating QC data. You take the QC data that has been generated and you go and plot it on the graph that has been developed. And we're going to see an example of that. So the next thing will be that you monitor your control value. And that is where the use of Westgard rules, the multi-row QC comes in. And then, of course, how we can even do it better using the Westgard Sigma control rules. You, of course, part of your procedure will be that you have a procedure for corrective action. When QC is out of range, what are you supposed to do? And there has to be documentation for every action taken, for quality control failure. The QC implementation steps also include, in granular terms, that you calculate the mean and the standard deviation of the control material for a single data population. Use the calculated mean and SD on the QC chart. Use the right QC rules for your method. Plot the control values on the control chart. And if a significant change occurs in accuracy or precision, then the QC rule failures alert you to the change. One of the things we'll be talking about, especially with the AI, introduction of artificial intelligence in the lab, will be how to use AI-powered software, to alert us to changes that happen in the lab so that we don't miss any of these changes. Then, of course, you investigate. You do resolution of any failure and document the rule failure before the patient results are reported. So I feel it's important, since we're talking about quantitative QC, we're talking about establishments of control charts, that we should also talk a bit about the principle on which statistical quality control operates. For every test that is done in the lab, there is a principle. For reagent that is used, it is actually a reaction of one thing with the other that can produce a particular result. So every of our tests in the laboratory has a principle. So is the statistical quality control. So this operates on the principle of Gaussian distribution. And I've taken time to explain this here, that this principle simply means that there are a lot of naturally occurring phenomena. And what this means is that these are often normally distributed. The normal distribution will mean, and then I give an example of the distribution of heights of human beings. The average height is found to be roughly 175 cm for both male and female. Most people conform to that average. However, there are taller and shorter people still in our population. But of course, there are lesser number of, these individuals, I mean, the taller and shorter people. So the same way we say, when we look at also average income of individuals, you have people that are just on the average, you have people that are extremely wealthy, you have, and this, at that particular level, they are also very few. And then you also have people that are quite poor. So according to the empirical rule, 99.7% of all people will fall within plus or minus 3 SD of the mean that has been calculated. In this example that I gave, 175 cm is our mean. That is like the average height, for most individuals. So 99.7% of people will fall within plus or minus 3 standard deviation of this particular mean, or between 154 cm to 196 cm. These other taller and shorter people will fall outside this, and that is just 0.15% on either side of the mean, as we can see, on this side. So we'll see that most people will fall within this, and then you can see the rest, on that other end. So that is actually the principle. And what this translates to in the lab is that if you run your quality control 100 times, representing percentage, 95.5% of the time, your quality control results must fall within plus or minus 2 SD, based on that natural phenomenon, based on that principle of Gaussian distribution. So what this tells us is that if you have any QC value that fell outside of this specified range, it means that it has disobeyed the principle of normal distribution. And it means that something is actually wrong with the system. So it is that same principle of normal distribution that LJ charts was actually developed. So if you look at this from the Gaussian distribution that we see, we can see it's just like turning the Gaussian shape, which is also called like a bell shape or a bell curve at this particular angle. And then you have this, that the mean, which is at the center, is actually the one that is turned to the, so if you follow me here now, you see this from this point, it is translated to the mean. So you see the mean, when we talk about calculating the mean, you draw your mean around here. So it means that the mean is here, and then you have your 1 SD, excuse me, you have 1 SD, you have plus 1 SD on this other side of the mean, you have plus 2 SD. So remember, we said that this occurrence is a normal one. And anything that is outside means that something is wrong with the system. And when that happens, it has to be investigated. So LJ chart is developed based on that principle. So the QC analysis relies on the ability, of course, to predict that any stable system will produce the same distribution of data on both sides of the QC chart. So let's talk a bit about development of this LJ chart. So we say there are two important statistics, and that is the mean and the standard deviation. The mean here is the average of a set of values, and it is used in the calculation to determine bias, measure of systematic error. Why standard deviation is used to measure distribution or scattering of a group of values around a mean. Is a primary indicator of precision. So when we talk about two important things about under reliability, we said there is the accuracy and then there is precision. So for these two statistics, the standard deviation will talk about the precision, which will be the one that is the measure, of that reproducibility. While the mean is the one that talks about how close the measurand is, to the target value. And of course, this is the formula for mean and standard deviation. So when we talk about how to establish quality control ranges, we run new control to obtain about 20 to 30 data points over a 30-day period. And this is an example. You run this in parallel with current control material. All new controls must be within the manufacturer's product package inserts range. You calculate the mean and SD, you develop your LJ charts and plot your results. So from here, you keep documenting day one, and this is an example of glucose control level 1. So you have 5.7 millimole per liter. You have all of this from day 1 to day 31, which is what is used, to calculate the mean. So here, we calculated, we got a mean of 5.6 millimole per liter, our standard deviation of 0.1 millimole per liter. So this is the data that you get when you run the quality control material. And we'll now take this, import this data, and use this to establish our chart. So if I can talk about that quickly. So it's just like having that data and you bring it to somewhere here. So your mean here, we said is 5.6. The 1 SD is which is the distance between the mean and the first standard deviation is 0.1. So if, for example, my mean here, like I said here, my mean is 5.6, my SD is 0.1. What we are saying here is that if you have this as 5.6 plus 1 SD will mean plus 0.1. So I will have 5.6 plus 0.1. And here we have 5.7. 2 SD will be 5.6 plus 0.2, which will be 5.8. And this will be 5.9. Then below the mean, you have 5.6 minus 0.1. Here you'll be having 5.5, 5.4, and then 5.3. So that is how to establish your QC limits on the developed LJ chart. And each time you now run your quality control, you'll be looking at how to place the data generated on the appropriate parts on the quality control chart. And then we'll talk about monitoring that later. So this slide just explains how do we come about the LJ charts. Is the work of two people, Stanley Levy and E.R. Jennings, who suggested in 1950 that Schwartz, Schwartz, it was considered to be the father of SQC, could be used in clinical laboratory. So they improved on the work of Schwartz, and then, so it used to be known as Schwartz charts. But now with their improvements, we have Levi-Jennings chart, which means that it's not only just individual quality control, but you can actually have it, for over a period of time. And this is an example of a well-filled quality control chart, having the name of the analyte, the lot number of the QC, the control material itself, the name, the expiry dates, the mean, and the standard deviation. So now that we've talked about how to establish QC limits and how to document on the LJ chart, let's look at what tells us that the QC, the performance is fine or not. We said we monitor the performance of quality control using multi-rules. And then we monitor that QC data using Westgard rules. So the Westgard multi-rule system was developed by Dr. James Westgard based on statistical concepts, and it's a combination of decision criteria or rules to assess if a system is in control or not. So it cannot use only one level of control. And this is the man himself, Dr. James Westgard, and this is the son, Sten Westgard. We've been privileged to meet Sten Westgard. He came to Nigeria at some point, I think during the ASLM conference in 2018. So if you want to know more about the Westgard rules, you can actually visit the website. So these are a common example of the Westgard multi-rule system. I will talk about, I think I have the first three. These are an example of what the rules actually mean. So we have the 1-2S rule, the 1-3S rule, 2-2S rule, R4S, 4-1S, 10X rule. And then these are so many other rules that, they are there. So the rules are actually, they have a particular nomenclature. So it's either you have it here in a form of superscript or subscript, and then if you have it as this here, or you have it like A ratio L. So A here represents the number of control measurements involved, and L, control limits, often expressed as the mean assigned to the LJ chart. So if I want to go back to the example I have there, I say there's 1-2S. So it means I will have this A will represent 1, and then this L will represent 2S. So if I say 1, and we say number of control measurements, it means that I'm talking about only one control measurement. That is what that 1 means. So the other example will be 2-2S. So in that case, this is A is 2. It means that we have more than one control measurement that is involved in the violation of that rule. And then this L will talk about the control limit. So when we say 1-2S, 2S will mean that this is talking about something that is outside 2SD limits. So if I say 3S, something that is outside 3SD limits. If you see 4S, it means it is up to 4SD when you count all of them together. So that is just explaining the rule nomenclature. So let's quickly look at a few examples. I have the first one that talks about 1-2S rule. I won't go through this, but let's just explain this because there's a picture explains better. So if you come here, you see, based on what I explained earlier, this is the mean, this is minus 1SD, plus 1SD, plus 2SD. This is control for run 1. It could be day 1, control for run 2. And the difference between run and days will be you can have more than 1 runs in a day. So if it's a lab that run control just once in a day, then this run can also be taken as day. So, but this run can be morning, afternoon, and evening shift. So let's say for this particular control, the run 1 was just on the mean, run 2 was on plus 1SD, run 3 came down to the mean again. This is a perfect example, but something happened during run 4. The control results was outside plus 2SD limits. This rule is a warning rule. So in the lab, we have what is called the warning rule and the rejection rule. 1-2S rule is a warning rule. And what that means is that it's violated when a single control, just one observation, is outside the plus or minus 2SD limit. Let me also mention at this point that the violation could be on this side. It could also be on this side of the mean. Once it is outside plus or minus 2SD limit, that rule has been violated. But look at the conclusion here. You don't reject patient's result. You don't reject a particular run. The patient result can still be reported because it is a warning rule. 1,3S rule is a rejection rule. If you look at this, this is what I explained earlier. And for this one, the result is outside the 3SD limit. It could be either on this side or on this side of the mean. So run must be rejected. Let's look at another example, and I think it's the last one for the multi-rule I want to explain. So it is 2,2S rule. 2,2S, remember we said this 2 means the number of control data that is involved, the number of control measurement that is involved, while this is talking about the SD limit that is involved. So here we are talking about 2 data of control, and here we are talking about 2 SD limit. So if you look at it, and it can happen 2 ways. It could be that there is 2 consecutive control values. In the case of this example below, where 2 consecutive control values for the same level fall outside of plus or minus 2SD. So this is the first one, was outside 2SD. You know, when it was like this, it is just 1 2S, and it was a 1 rule. But the next run was also outside plus 2SD limit. So this is a violation of 2,2S rule. The other example would be that it is 2 level of control. Level 1 was outside 2SD. Level 2 was outside 2SD in the same direction. For it, when you are talking about 2,2S rule, and you are talking about 2 levels of control, then it has to be in the same direction for that rule to be violated. These are some examples of the rules that I want to talk about. I'll quickly switch to the Westgard Sigma rules. You know, we've been talking about the Westgard rules. So, and is the multi-rule QC. So the Westgard rules uses a combination of decision criteria to decide whether an analytical run is in control or out of control. In control means you can accept your result. Out of control means that you need to pause, investigate before you can accept the control. So the well-known Westgard QC procedure uses 5 different control rules, which I shared earlier on: 1 2S, 1 3S, 2 2S, 4 1S, and all that. Over time, Westgard have developed a variety of QC design and planning tools to support lab efforts and to select QC procedures that are right for their specific intended clinical use. So the Westgard Sigma rules is actually an improvement over the traditional Westgard rules. So a new tool called Westgard Sigma rules was developed to achieve this purpose, and as well to distinguish this approach from the original Westgard rule. We are going to look at what that means. So remember we said Westgard Sigma rules, and I said it's an improvement, meaning that they want to be looking at the rating based on the sigma number, based on the sigma level of that lab. That you don't just use the Westgard rules and make it applicable to all levels of lab, but it has to be based on the particular level of lab. And remember, sigma is a measure of quality. So Six Sigma is a quality discipline that focuses on product and service excellence to create a culture that demands perfection. The methodology was developed by Motorola to reduce the cost of products, eliminate defects, and then, of course, it has 5 steps. We call it do, make, define, measure, analyze, improve, and control. I think in previous sessions we talked about this before. So the sigma value indicates how often errors are likely to occur. So the higher the sigma value, the less likely it is that the lab reports defects or false test results. And what it also means that the lesser number of rules that will be applied to the laboratory. This is a big of defining how do you now determine or calculate the sigma number for your lab. So the sigma is calculated using these parameters. You need the total allowable error limit for that particular analyte in question. The bias is calculated, and then of course the standard deviation is calculated. So the bias is the difference between the results obtained by the lab test method, which is the mean, and the result that will be obtained from an accepted reference value, the target value. So most of the target value, you get it from, let's say, maybe from a PT sample, from a reference laboratory. And then the standard deviation is the total analytical standard deviation of the test method. We have shown an example of, the formula for calculating standard deviation earlier. Bias simply means the mean minus the true value. So when you have the total allowable error limit, which is a constant and is often available in literatures, there's what we call the clear limit. So it is something that is available. So you calculate the bias, and the bias can be, if you have it in the essence of the absolute value, is to turn it, if it is minus, to plus. So these are things that are basic mathematical expression. So this is the formula on how to get your sigma value for the lab. Then the right selection of QC rules impact the QC program significantly by maximizing error detection capability and reducing false rejection. And I've explained this before, and then we are going to see how this plays out using this chart. So this is an example of Westgard sigma rules for 2 levels of control. Now, what this means is that if the lab is operating a 6 sigma scale laboratory, you need only one Westgard rule to decide whether to accept your results or not. So if you look at this, you apply only the 1,3S rule. So if the 1,3S rule is violated, that is yes, you need to investigate and take corrective action. If the answer is no, you simply report your results. Now, if the lab is on 5 sigma scale, then you need more than one. You'll be starting from 1,3S, going to 2,2S, and going to R4S. When R4S rule is not violated, you report your results. If it is violated either at 2,2S or at R4S, you need to investigate and take corrective action. So for 5 sigma, you need more rules. Now, for 4 sigma level, you even need additional rule of 4,1S rule. And then when it is 3 sigma, of course, you need up to about 5 different rules. So this is your QC data subjected to different rules. So the main catch of Westgard sigma rule is that the number of multi-rules that is needed for acceptability of run in your lab depends on the sigma rating of your laboratory. That is just the concept. And that is what has been explained on this part. Let's continue. I'll be transiting to proficiency testing, which is also a part of what we are supposed to discuss. And then external quality assessment, which is a system. I think this is one of the poll questions, which is a system for objectively checking the laboratory's performance using an external agency or facility. It means a lot of people's results, peer results, are put together, to find the reference values, and then this is actually determined. And then 3 methods of EQA. We have the PT, and I made bold to say that PT is the commonest of all the EQA methods. We also have the rechecking and retesting. You have on-site evaluation. Let me quickly touch on rechecking and retesting. Rechecking, of course, is used mostly in a TB program AFB microscopy, AFB microscopy to be specific. And then this simply means reading again slides that have been previously read, by the first reader. So we say we have the first reader, the second reader. It's also used in malaria SMEC, malaria microscopy. So previously read slides are taken and read again by expert readers, to know how well, the laboratory is doing. And retesting on the other parties, when you have to retest maybe HIV serology sample result has been previously generated. So you can either use the same method or use the higher method. And then on-site evaluation will mean the use of checklists by an external people, visiting your lab, and then looking at some questions on the checklist to know your level of compliance. And then I'll come back to the main one, which is common, which is the proficiency testing process. We have two stakeholders, the PT organization or PT provider and the laboratory that is receiving the PT panels. So the PT provider prepares PT panels. Example is the foundation that is supporting this webinar, the College of American Pathologists. One of the things they do, among other things they do, is they prepare proficiency testing panel. One of the labs we support actually subscribe to CAP PT program. So they prepare panels and send the PT samples regularly to the lab. The lab receives the PT sample or panel, analyze it, generate results. From that, the result is sent back to the PT provider. The PT provider evaluates that result, compare the values obtained by the lab to their own reference value. And let me mention quickly at this point that method of evaluation is either the use of what we call a reference method or a consensus method. Consensus method will mean pulling together all the results submitted by different labs, calculating the mean and standard deviation, and know which lab is actually not within that range. So they evaluate and generate a PT performance report. They send this back to the laboratory. The lab receives that report, check. If everything is fine, 100%, they review that, sign off, nothing to be worried about. And then if there is a failure, they need to investigate that and implement corrective action. So that's essentially what PT process looks like. Let's look at some in-country data. Okay, I have a slide also that talks about interpretation. This is an example of the report that is generated by the PT provider. They have the name of the test will be there, the results submitted by the laboratory. The Z-score is often calculated to know where on the chart, which SD limits, the lab falls. When there is failure, it is flagged. The number of labs participating in that PT will also be documented. The target value, which is the method mean, which I said could be obtained through a reference method or through a consensus method. Then the SD and CV. So this is an example of a PT report from a PT provider. Let's look at what happens currently in Nigeria. So we have PT providers, and this list are not exhaustive. So we have a National AQA Laboratory, NEQUA Lab, that is operated by Medical Lab Science Council of Nigeria. Their lab is in SAE, and currently they provide PT panels to over 600 labs. Over 600 labs are registered, for different assays, mostly HIV serology, CD4, chemistry, hematology, and other serology assay. Then, of course, we have College of American Pathologists in US, which, like I said, is the foundation that is supporting this webinar. And then about 3 of the labs I support actually subscribe to this for their serology and for their chemistry. So we get the panels from US, and then we run samples, send result back, and that is what we have actually been using, for some time now. We also have the National Health Laboratory Services, NHLS, in South Africa. We have IRISEV in Senegal. The National HIV Program also in Nigeria also produce PT panels by different implementing partners. We have CDC International Lab Branch in Atlanta. We have National TB and Leprosy Control Program in Nigeria. They produce panels for TB for both gene experts and AFB microscopy. Then there is also the Supranational Lab in Milan, Italy, that also send PT panel for DST. So most of these PT providers that subscribe to, most of the labs that subscribe to NEQUA, they are labs supported by PEFA program in Nigeria, and then they are the ones that actually support to make sure that these panels are available. We have individual labs too, not so many, private labs, government-owned labs that subscribe directly, to these PT providers, but the number is quite few. And then I'm gradually coming to the end of the presentation. I have a few slides, I think just about 2, to explain the artificial intelligence in a QC control program or QC control, quality control monitoring and automation in laboratory workflow. So I have this slide and I think 1 or 2 more slides to explain that. So when we talk about the use of AI in clinical lab, we're simply talking about machines and computers that mimic human intelligence through learning and programming. We talk about generation of algorithm, that is set up based on a lot of data set that has been generated previously. And we're training these machines, these computers, to be able to reason the way human beings will reason, to perform tasks that may even be burdensome, to human brain. And then it has actually been in existence for close to 70 years now, and has been used subtly in most of the automated systems, including laboratory automation. The use of AI in clinical lab has been demonstrated in few labs based on available information. But we have only few labs that have actually taken this, to say that, we are concentrating on this, relying solely or mostly on artificial intelligence to generate, results, especially in our predictive diagnosis. So talking about the place of AI in quality assurance or quality control, I have a few examples of what maybe I've experienced or what has been documented. So AI can be programmed using the algorithm to identify QC patterns and trends that result in automated flagging. So when QC is out of range, AI can be programmed to identify this, flag it for attention of the laboratorian. We've also seen cases of use of AI in clinical interpretation of lab results. And now this is a personal experience. So we used a software some years back when I was on the bench. And then this software can look at results generated from a complete blood count, looking at the different parameters, looking at the suggestion, from the film, and can suggest a blood film comment. You need an hematologist that will look at the film, to report findings for use of clinician. But these LIMS, the AI-powered LIMS, has been programmed in such a way that looking at the data generated and based on previous reading. And when you now talk about previous reading, we're talking about previous readings data that has been generated by a human being. hematologists that have looked at the film and said that, oh, when I see this type of reading, it is suggestive of this particular condition. Layering on that, the limbs can suggest the clinical interpretation of such results. Also used in the immunoassay, and then the lab will now need to select the appropriate comments, and it goes out with the patient report. The predictive capability of AI can also be leveraged in equipment maintenance to indicate possible breakdown. And then it can prevent automatic shutdown because there will have been prior warning that, oh, based on what I'm seeing, based on the data that is generated, especially maybe for equipment that have some background checks, you know, something that is not necessarily showing that there's a problem already by looking at it, but by comparing trends of what has happened in the past, the program can actually indicate possible breakdown. And then this can make you to say, oh, let's quickly do a preventive maintenance so that there will be no shutdown of the system. The AI-powered LIMS can also be used in Delta check. Delta check is comparability of patient results, comparing the current results with the old results. So this Delta check, and this one also, I've experienced this, that when you are, if it's a patient that you have on the lab information management system or hospital information management system, with the identity matching, and let's say it's a patient that is being monitored for diabetes or something, and then you impute a new glucose result. And if this is different from what the patterns has been, it will prompt you to check your system again and say that this is not the results, you know, that you've been previously getting for this particular check. So the essence, of course, is to ensure reliability of results. And then, of course, it's also been demonstrated in automated review or approval processes and predictive inventory use to alert reordering to avoid a case of stockouts. Now, I'm rounding up. Is the lab ready for AI? For this AI to be beneficial and improve the lab system. And okay, let me pause at this point. When I was preparing for this, I had to talk to colleagues in US and in UK and see how much is the lab dependent on AI now. And what I got, and even in country here, is that, oh, it is something that though has been on, and then it is not been totally used. Let me use the word. The lab has not been handed over totally to artificial intelligence. So it is still like work in progress. But for this to be beneficial and improve our system, setting up the algorithm properly is key. Algorithm is sequence of how things will happen. So if you want to look at the meaning of algorithm in a programmatic manner, we can understand this from maybe the algorithm of running HIV tests. The national HIV algorithm is as simple as that. That you say, okay, for you to confirm a diagnosis of HIV in Nigeria today, you first run the first line test of determine. If determine is reactive, you proceed to Unigode or a second line test. And if it is reactive, before you can say that this client is positive. So this kind of system has to be properly set up. Remember, the program, the computer, will only react to what you have programmed in it. So setting up the algorithm properly is key. And this also means that when you want to, and this is addressing, I think, the last point here, that when you are setting up AI models, it requires collaborative efforts, the medical laboratory professionals, the IT experts, and other stakeholders. And I want to use this to challenge, you know, the laboratorians on board that most of these, I mean, the truth is that most of the laboratory information management system that it's actually being introduced nowadays are have some elements of AI. So you see AI-powered LIMS. So it is important at the point of installation, or even at the point the management is negotiating, you know, for the suitable AI for, the suitable LIMS for the system, that will work with them and see that what is actually going to be used as LIMS is something that will respond to the need of the lab. So we should not stay back. And then, of course, for this to work, there is the need for pre-service and in-service training and retraining of medical laboratory scientists. And on this slide, I want to draw out some key messages based on what we've been talking about. The first one is that a quality control program allows the lab to differentiate between normal variation and error. External quality assessments is a system for objectively checking the laboratory's performance using an external agency or facility. And for artificial intelligence to be beneficial and improve the lab system, setting up the algorithm properly is key. In conclusion, and I said this at the beginning, that any laboratory test conducted without a valid QC program is considered a harm to the patient. So we should think of it and avoid the harm to the patient. This picture, I took it from one of the labs in Jos. So if you are from Jos, shout out to you. That no results at all is better than a false result. I'd like to acknowledge WHO's LSI Laboratory QMS Training Toolkits, the National QMS TOT Curriculum, ISO 15189-2022, this book on Practical Guide to ISO 15189 Lab Medicine by David Bonnet, the SLAMTA Training Toolkit, and of course, Baraka Consulting. And this is me greeting you from Abuja. I want to thank you so much for your attention. I'll ask Dr. Basil whether I'm to take this announcement or you want to take this announcement.
Anyway, it's fine. Please go ahead.
Okay. All right. So next week, the webinar continues the same time, and the topic will be ensuring compliance through laboratory assessment and audits. And then the key components of that, the outline will be how to conduct internal audits for quality improvement and accreditation readiness. They will also be looking at key elements of ISO 15189 compliance and regulatory expectations. And then the facilitator will also be talking about some digital audit tools available that will enhance accuracy and efficiency in assessment. We've been told before that, you know, for details, for inquiries, you contact the details that has been provided. So on this note, I want to thank you so much for your attention, and then I'll be happy to take your questions and comments at this point. Thank you so much.
All right. Thank you very much, Dr. Emmanuel Ojo, for the presentation. It was a very succinct and direct one. I think we all heard you loud and clear. And I want to thank the IT team also for making this one very hitch-free. All right. We have. You can go ahead and ask your questions now.
Hello. Hello, good evening.
All right, please go ahead and ask your questions.
All right. Thank you very much, Dr. Ojo, for the presentation. I have two questions. One is where you talked about the proficiency testing. When the lab, after the proficiency testing, will be comparing the result with that of the body that prepared the panel. And you mentioned that it has to be 100%. I was just wondering, it is difficult for a lab to repeat the tests, even by the one that it did by itself and get 100%. So is there not a kind of range or a percentage of which will be deemed acceptable, instead of saying it must be 100%? Okay, that's my number one question. Then two is that concerning the Westgard rule, I've always been wondering the practicability of this rule, in the sense that the lab will have to, for instance, a lab that uses like runs two sets of control in a day. For one to be able to plot the graph, the Levi-Jenis chart, and be able to make out something from it, it means that one would have finished like 2 days, okay, to be able to plot something that can now be used to judge whether the controls have met the required rules or not. So I don't seem to really understand how that chart will be used to make decision on a current lab result that before it can be reported in a day. Okay, because before one can come to plotting that graph, it would have been the controls used in the past. And if that is the case, I wouldn't know. I'm still having issues understanding how it will be used to make a decision in the current day, because it's the control of the past that you are talking about, not the control of that present day. And if you are to talk about the control of that present day, you will not be able to have enough control to plot the required Levi-Jenis chart. Thank you.
All right, thank you so much, Mr. or Dr. Emmanuel. Pardon me, I didn't get the, and thank you. That's a namesake. So thank you. I mean, that's very apt, the question. So to start with, and please, Dr. Basil, there is a question on the chat box that talked about getting the slides. So you may want to respond to that on the chat box because I don't know what your plan is about the slides. To the question about, I will start with the last one, application of Westgard rule, how possible it is and all of that. You are correct to say that, and this is what I talked about when I talk about the implementation steps. The first thing you do is that the charts that you are preparing, which you'll be plotting your current data on, it's going to be prepared from previously generated control data. And on this slide, I said that you run new control to obtain 20 to 30 data points over a 30-day period. So in actual, how this is implemented is that when you know that your QC is going to run out maybe in the next 1 month, it means that you need to have procured a new lot. My second bullet point here is saying that you run this new control in parallel with current control material. So while you are gathering data to establish new QC limits, you are still using the old quality control that you must have established the QC limits and the Westgard rule, you know, to decide the acceptability of your run. But you'll be running this data for the new control. I mean, you'll be running this new control to generate new set of data, and you'll be keeping the results. it is not that result that you are using to validate your current testing. So when you are finished running, so let's say that in January, for the example I gave, I must have an existing QC program that I'm running. But in addition to that, because I need to establish QC ranges for the new lots, I will start running and keeping my data until I'm able to now calculate the mean, the standard deviation, and plot that. So once I'm able to put that here, let's say from February 1st, I've exhausted the old one, and I've established my QC limits using that data collected in January. From February 1, I can come here and start plotting. And immediately I'm plotting, then I can know where my data actually falls for that particular run. So that has answered that part. And to also mention that there are now automated systems. Even simple Excel has been optimized that once you are putting your QC limits, the main, the SD plus 1 SD plus 2 SD minus 1 SD minus 2 SD limit, you can start, once you enter the data, it will plot the graph for you. And it will even tell you of the rule that has been violated. That's one of the examples I said about AI-powered softwares. So it is something to answer in a simple way. You use previous data to establish the QC limit. And I hope that is clear. So that's that about your second question. The first question about proficiency testing, I didn't remember saying that you have to score 100%. And that is actually not the way this is actually being evaluated. So the process is that whether you are using a consensus method or you are using a reference method for evaluation, that's the PT provider now. What you do is that you are going to calculate for each run what we call a target value or target mean, and you have the plus or minus 1 SD, plus or minus 2 SD, and you decide whether your acceptable limit is at plus or minus 2 SD or plus or minus 3 SD. So the for you to pass that particular analyte, you must be within that acceptable range that has been defined by the PT provider. In most cases, it is plus or minus 2 SD. But some do allow to say that, oh, if it is not outside plus or minus 3 SD, it will be taken as warning. So it is acceptable if it is that. So they are the one that will decide that. So it's often a range, not a fixed percentage. I think that has answered your question. Please confirm to me that that is okay. Emmanuel.
Oh, yeah, thank you very much. You have done justice to the questions. Thank you. I appreciate it.
All right, thank you. I can't see any other question on the chat box. So please, if you have anyone, you can unmute and ask the question directly. Thank you for the compliments on the chat box. I appreciate you all.
Thank you very much, Dr. Joe, for the presentation and your responses to the question. Unfortunately, we will not be taking further questions. We look forward to getting them as emails. And when I get the email, any questions, I'll forward them so that you can respond. Thank you very much, everybody.
That's fine.
All right. We appreciate your attendance. We appreciate your presentation and everything you've done. We look forward to the next presentation, and we expect you all to be here again with us. For now, it's bye from this side.